So we've touched on this question a little bit, but I think it's important enough to be worth coming back to more directly. When there's a strong next-line targeted therapy option, such as lorlatinib after alectinib, do the panelists still recommend repeat biopsy at progression before starting the next line treatment?
Yes, I do. So again, I think it comes back to your question, right? So it depends on the patient. So if you are a patient that wants that information, and I think you can still learn things in that setting from doing the biopsy. But will lorlatinib have a good chance of working without that information? And if I have the opportunity to try it without that information, I think it's a very reasonable strategy as well. The reason I said yes starting off is that sometimes we do find things that might steer us away from that therapy. For example, in the context of ALK-positive lung cancer that you're going to hear about, sometimes there's extra growth signals that can come along. So if I knew that you had now an alteration in a gene that wasn't ALK, I might feel less enthusiastic about proceeding with lorlatinib. But I think, again, it depends on the context and the situation. One could proceed without that information, but I think it's also helpful to be as informed as possible.
Yeah, I think that's really well phrased, right? So there are things that I see in my consultative practice that I say, well, that's not my style, but perfectly reasonable. And there are other times that I'll admit I say, I'm sorry, they did what? And this is more in the, my co-panelists are both laughing, but come on, you guys have consultative practices, right? This is what we do all day long. So, fortunately in lung cancer, I think the majority of the time that something's different from my practice, it's more a question of style or academic community preference than necessarily wrong. But this is such an area, right? I think there's nothing wrong. When I see a consult of a patient who had alectinib, their cancer progressed, and they go on to lorlatinib and brigatinib, there's nothing wrong with that. That's not something that I teach my fellows, this was wrong. On the other hand, the patients who see me, who drive to an academic practice, are going to be patients who want a little more information, who want to really go to the mat. There are times that it influences my choice of lorlatinib versus brigatinib versus actually moving back to crizotinib versus thinking that none of these are likely to help the patient. And yet, in parallel with that statement, the overwhelming majority of the time, the answer is that lorlatinib or brigatinib would be just fine. And even with full information, it's usually a toxicity profile-based decision, not one based upon the molecular data. So I guess the answer is it's both, right? This is where there needs to be shared decision-making and a conversation about it. And it's a little bit different by, I think, by what mutation and what you're looking for. So back in the day, before osimertinib became dominant in frontline, there was one resistance change that was 60% of resistance after gefitinib or erlotinib. And there you really needed the resistance testing to know if osimertinib was the right thing to do, because it was the only thing approved in that context. ALK is a great counterexample where the overwhelming majority of the time you're going to get it right without molecular testing. And as we get into our newer changes, it's evolving and we're just really learning about it now.